Hello, in this video I'm going to talk about the oculomotor nerve palsy. If you haven't seen my previous video in which I have discussed the extraocular and intraocular muscles and their nerve supply brief discussion, then I would suggest you must watch that video first so you could have better understanding of the of the subject. So in this picture you can see that this is the typical picture of the oculomotor nerve palsy. You can see in the left eyelid drooping, and you can see the eyeball is deviated laterally and depressed inferiorly, and bit about the size of this pupil, which is dilated. So these are the three typical features of the oculomotor nerve palsy, which is drooping of the upper eyelid, then deviation of the deviation to the lateral, and the in depression of the eyeball, and number third is dilatation of the pupil. So I'm going to discuss each of these symptoms on their anatomical basis one by one. This again, this diagrams you can see very well. The here you can very appreciate the dilated pupil as well, and deviation of the eyeball to the left and depressed as well, whereas the finger of the examiner, it has supported the upper eyelid, so you cannot appreciate the ptosis here. So I would, if you remember, in my previous video regarding this subject, I stressed upon this muscle, which is levator palpebrae superioris. This muscle, I told you, had two parts. One is skeletal muscle part, other is smooth muscle part. So skeletal muscle part, like all other major extraocular muscle, it is supplied by the third nerve palsy. So in case of third nerve palsy, third nerve is damaged, so skeletal muscle part is damaged because it is paralyzed, because of there is no motor fiber coming from the third nerve. So as a result, motor part would be, skeletal muscle part would be paralyzed, whereas smooth muscle part would be still in working condition, because the smooth muscle part of this levator palpebrae superioris is supplied by the sympathetic nervous system. So in the next thing is that why there is dilatation of the pupil. So dilatation of the pupil can be explained by this diagram. This is purple one is the parasympathetic fibers, and blue one are the sympathetic fibers. Sympathetic fibers supply the dilator pupillae, and purple fibers, they supply the sphincter pupillae or constrictor pupillae. These are parasympathetic fibers coming from the Edinger-Westphal nucleus, which is the parasympathetic nucleus of the third nerve. So when this third nerve would be damaged, there wouldn't be any parasympathetic fiber supplying the constrictor pupillae. So constrictor pupillae is paralyzed. As a result, the dilator pupillae, which is unchecked or unbalanced, because these two nervous systems, sympathetic, parasympathetic, or dilator or constrictor pupillae, they check each other, or they are in balance with each other. So whenever one muscle goes weak, the other would overcome the action of the its counterpart. It means that if dilator pupillae would be paralyzed, then constrictor pupillae constrict the pupil, and vice versa, which is if constrictor pupillae dilator pupillae would be constrictor pupillae would be paralyzed, dilator pupillae will come into action and it will dilate the pupil. So in third nerve palsy, we all know that third nerve carries the parasympathetic fiber. Parasympathetic fiber is gone, constrictor pupillae gone. Constrictor pupillae gone, it means the its opposite force, which is dilator pupillae, it is unchecked. So as a result, pupil would dilate. So in the third thing is that we all know that medial rectus, lateral rectus, superior rectus, inferior rectus, and superior oblique, except for lateral rectus and superior oblique, they are supplied by, lateral rectus supplied by the sixth nerve, which is abducens nerve, and superior oblique, which is supplied by the fourth nerve, which is trochlear nerve. So these two muscles, they have their own nerve supply, whereas rest of all major of the extraocular muscle, like superior rectus, medial rectus, inferior rectus, inferior oblique, and levator palpebrae superioris, they are all supplied by the oculomotor nerve. When there wouldn't be oculomotor nerve, all the extraocular muscles would be paralyzed except for the lateral rectus and superior oblique. So lateral rectus would pull the eyeball towards itself, so eyeball would be laterally deviated, and this superior oblique it's a bit tricky, but in my previous video I tried to explain its action as well. So here you can see that the superior oblique is goes anteriorly. This is green hook or pulley around which it takes a turn or make a sling, and it comes and attached onto the posterior part of the eyeball. This is the line which this line divides the eyeball into anterior and posterior part, and this is equator of the eyeball. So if you look at this thing carefully, this superior oblique is getting attached on the posterior aspect of the this eyeball behind this equator. So when this muscle would pull, it will pull the raise the posterior part of the eyeball. As a result, from anteriorly the eyeball would be depressed. So action of the eyeball, this superior oblique would depress the eyeball, and lateral rectus action of lateral rectus would pull the eyeball laterally. As a result, the eyeball would be in this position, which is laterally deviated and inferiorly depressed. So this was bit about the I guess all three typical features of the oculomotor nerve palsy have been explained: ptosis, deviation of the eyeball to the left, and depression and dilatation of the pupil. Thank you very much.